Well, good evening, everyone, and welcome to our lecture series. Today we have a special series webinar planned for you, and it's our Nurse and Technologist seminar. Next slide. These are our course directors, and we range from a variety of specialties, including cardiac surgery, interventional cardiology, and cardiac imaging. Acknowledgements to our industry sponsors, without whom this would not have been possible. And a special shout out to AstraZeneca, and please check out their product theater. For CME certification, these are the instructions. You do have to go to that CME website, cme.northwestern.edu, and you have until May 3rd to receive credit. Next slide. The same thing for the MOC certification. And just as a reminder, the MOC and CME evaluation will become available on April 8th. For tech support, that's the website, cvconferences@northwestern.edu. And like I mentioned earlier, that you will have time to claim credit until May 3rd for CME and MOC. Also, as a reminder that all sessions are recorded and they're available 3 business days after the live date. You can also follow us on Twitter. These are our Twitter handles, and with the hashtag HTS2020. And just to briefly summarize, all the 3 institutions, Accession, St. Vincent, WashU, St. Louis, and Northwestern, have been nationally ranked for cardiology and cardiac surgery. And also, just as a reminder for our audience members to check out the All of Us research program. This is a longitudinal effort to gather data from 1 million people within the US. You can learn about this at joinallofus.org or these social media platforms, or you can check out the NIH website. And with this, I'd like to hand it over to Alan, who will introduce our next speaker.
Thank you, Nishat, and good evening, everybody. Thank you for joining us once again at our CAR Team Summit lecture series. As Nishat had mentioned earlier, this is our second symposium that is centered around allied health professionals and technologists, and we have a very exciting roster, and hopefully you'll find it just as interesting as we have. Without further ado, I'd like to introduce Holly Crump, who is one of our valve coordinators at WashU, who will then take over introducing our speakers. Holly, if you.
Hello, thank you, Dr. Zaharias. Our first speaker we'll have is Liz Perpetua. She is the founder and CEO of Empath Health Services, a tech-enabled consulting company in Seattle. She's been a cardiac nurse for 20 years, board-certified adult and acute care nursing practitioner for 13 years. She's going to be talking to us about implementing treatment pathways. Liz?
Thank you, Holly. And I'd like to thank the course directors for the kind invitation to present on implementing treatment pathways. I will go ahead and get us started with these objectives. So first, I'd like to contextualize the concept of implementation in current era cardiology. I'll also introduce concepts and tools for successful implementation. We'll also deconstruct it using evidence and real world examples of best practices. And I will end by calling us to action as a cardiovascular team community. So first, for those of us who are in the audience, panel and so forth, I'd like us to just take a moment to reflect. What's one thing you've done to improve patient care in your program? What inspired you? And what was the impact? And what is one thing you've wanted to do but haven't done yet? So I'd like to frame today's talk by getting some personal meaning right out front. So the challenge of implementation is change. On average, it takes 18 years for clinical research findings to be adopted into our mainstream practice. And you can imagine in cardiology, that kind of gap is acceptable. We're not thinking in terms of 2 decades, we're thinking in terms of door to balloon times, and time is muscle. So the innovators, the innovation that we have in cardiology requires that we must be primed for change and implementation. And as you can see here, to be able to traverse this steep part of the learning curve, the diffusion of innovation curve, it really means that we must have these cultures that are primed for change. And one of the prime examples of rapid knowledge translation really is transcatheter aortic valve replacement, or TAVR. And here you can see Dr. Carroll and colleagues' paper from the end of last year that looked at trends in TAVR over about a decade now of experience, where we can see really as indications expanded, volume grew exponentially, outcomes got better. There was just this unprecedented rapid translation of evidence, and certainly not, the kind of decades, long translation that has been seen in other specialties. And, we went from our patients in 2011, very much looking like this as the norm in our valve clinics, to then, in 2019, learning of Mick Jagger undergoing his very own transcatheter aortic valve replacement. And now where, many of our parents now with this mature, mainstream therapy are able to have this option on the table. And so how did this really occur? Accelerating knowledge to action requires alignment of vision, values, people, and process. And again, just what has been done in transcatheter valve therapy is really a prime example of this convergence of health systems, industry, regulatory agencies, and the professional societies working together, as you can see on the left in this Venn diagram. We've really got the sweet spot there and have worked hard to maintain that alignment. On the right, you can see that this team-based care approach has been crucial to the success of this implementation. And really, I want to point out that it is the cardiovascular team that's delivering 95% of patient care, particularly in the acute care setting. And I want to point out and really underline how critical the cardiovascular team is to the success of all implementation. What we do is implement. And so amongst all of these models for managing complex change, the vision, the skills, the incentives, resources, action plan, all the ways that this can go wrong, right? You look at Cotter's why transformation efforts fail, what leads to false starts, frustrations, resistance, anxiety, confusion. Here it's laid out pretty nicely. And this, again, alignment to get to success is just missing something. And I want to point out that what's missing there is leadership, and we need leadership. And I want to point out that everybody is a leader. Every single one of you is a leader. A leader is anyone who takes responsibility for finding the potential in people and processes and has the courage to develop that potential. So you find me a cardiovascular team member that isn't leading in some way right where they are. And that, again, has been critical to the implementation and the success of implementing treatment pathways that we've seen, not only in transcatheter aortic valve replacement or structural heart disease, but in heart failure, in electrophysiology, in mechanical circulatory support, in the lipid clinics, in anticoagulation clinics, and all the arenas where cardiovascular team members and cardiology is caring for patients. And now, really, it's not where you take things, it's where you take them to. And this is where I think of the end in mind. We begin with the end in mind and the sum of the whole being greater than the sum of its parts. And one of the tools that I use as best practice is a logic model. So often in healthcare, we're doers. We just want to get in there, want to get it done. And we're really good at that, right? We might not even introduce ourselves to one another. We're just going to get it done. But there is an opportunity to plan. And in doing so, a logic model is a wonderful way to implement a treatment pathway and to kind of understand what the landscape is. So first, what are the inputs? So that's the basics, the why, who, what, where, when. Activities, how will we get these things done? Outputs are how many, and outcomes are how well. So pretty simple, right? The short, medium, and long-term outcomes. And there's these processes and outcomes that we can evaluate along the way and should, to be able to understand how successful we are in our implementation processes. And if we have these resources, then we can produce these activities. And then we have, these many patients treated or these many procedures, performed, these many lives saved, and our outcomes and our impacts look like this. So a logic model is a really nice way in a one slide, a one pager to simply, demonstrate how you want to implement a treatment pathway. And of course, what I want to point out here is what are you going to measure? And this is a wonderful resource from the CDC Division for Heart Disease and Stroke Prevention if you're looking at program development and program evaluation. Our why is really all of these guidelines, right? We've got more recently the 2020 guideline for managing valvular heart disease. So the evidence, the guidelines, that's our why, that brings that patient to our care. And you can see how convoluted this is, how rich this is. There are many guidelines that are embedded or related to a single guideline. And so it's even more important as we figure out the how with these decision pathway aids and these tools that we can utilize from the professional societies and from the community at large, that we are also understanding what works best for our own organization in a site-specific way. There are standards, but the workflows, the logistics, and the how really is something that occurs at the site level. Now, best practice is also that while we do things in a programmatic fashion so that there isn't a single point of failure type of program, we must also know we can't focus solely on process and results. We have to know that the heart is people, our patients and our team. And the National Academy of Sciences or Institute of Medicine has this incredible paper, Core Principles and Values of Effective Team-Based Care, that outline what we need to see for effective team-based care, which is what we do in cardiology. It's shared goals, clear roles, mutual trust, effective communication, and measurable processes and outcomes. And how important is this? Well, it's more important now than ever, perhaps, because of the kind of compassion fatigue, the burnout that we're seeing and even saw before the COVID pandemic, and is just so much more palpable and poignant now for us to attend to, because these principles actually have quite an impact on clinician well-being. If there is mutual trust or psychological safety, if I know somebody has my back, if something gets missed, somebody's going to catch it, and we're there for each other, and the processes that we accomplish are measurable, that we're getting feedback on those things, and we know that we're improving, we know we're helping patients, that transparency really adds to our resilience. And that's what we are definitely seeing and moving toward. And this is just another image showing that in a Donabedian model, where when we look at structure, process, and outcome, when there is leadership that expects that kind of accountability and is looking at people and process, we can have the kind of outcomes that reduce adverse events, that decrease patient mortality, and that improve patient satisfaction. And we must all be a part of it. All the end users, everyone on the front line, whoever is touching the patient has to be part of implementing a treatment pathway. Because tell me and I forget, teach me and I remember, and involve me and I learn. And sort of the other version of that is see one, do one, teach one. But we've got to be there. We've got to connect. And CV team members contribute to these pillars of care: quality, people, service, growth, and value. We're delivering safe, evidence-based care. We are facilitating or even directly overseeing program operations, decreasing wait times to treatment, serving as the front line if you're in the cath lab, if you're an echo tech or a radiology tech doing CTs. Everybody is contributing to helping your center be a program that has the kind of quality and the communication and the outcomes that make your center the kind of place where patients want to go, referring providers want to send their patients, and where people want to work. And so your contributions are indeed meaningful, and I want that to be known. Now, in theory, right, there's no difference between practice and theory, but in practice there is, right? It's messy. Real world is messy. And so another best practice that I have is to conduct a gap analysis. So what is your baseline state, or where you're at, and what is your desired state? Where do you want to get to? And what is that gap? And there are many committees or other departments in your organization that can also help in doing this. You know, obviously in transcatheter valve therapy, we have the TVT registry that gives us some guidelines and benchmarks on, you know, what our desired state may look like. But there are also other organizational or institutional factors to consider, and understanding that gap is how we transform it. And there are certainly processes and analyses like SWOT analysis and other methodologies like Six Sigma or Toyota Lean that can assist in the process. A best practice that I like to use is a fishbone diagram that allows me to see what are the root causes or these specific challenges and opportunities where there may be the highest yield. So for example, in the COVID pandemic, as we've been trying to decrease the number of trips that patients have to be evaluated, and really trying to, you know, meet the patient and receive the right care and get them the right care. A lot of sites that were still performing very comprehensive evaluations had to streamline those. So if they were performing, you know, PFTs routinely or carotid ultrasounds or dental evaluations and so on, just these simple moves to really, you know, ask how can we optimize this care and ensure that it's indicated, and then looking at what is actually in the literature to determine if a study is indicated or not. So I just want to point out here that even from the Society of Thoracic Surgeons, American Board of Internal Medicine, PFTs and carotid artery ultrasounds are only obtained if indicated. And that's their recommendation, but it's not often, you know, well known, and it's certainly not addressed in the decision pathways for valve disease at this time. But it's in, you know, understanding and doing this kind of literature review and connecting with the community at large, where you might understand that there are these additional opportunities where, you know, perhaps you can contemporize care and also learn from one another. And that's something that we did recently in a manuscript that I was very fortunate to write with a number of colleagues from across the country that you can see here from different geographies, where we were looking at how can we create a framework that is really a how-to that could be generally applicable, but help people with triage, surveillance, and risk stratification, as well as resource allocation during the COVID-19 pandemic, but also any type of crisis where capacity may be constrained. And so we call this manuscript the PEARLS manuscript, or Planning Efficient and Resource Leveraging Systems. And using a set of principles, really this framework aims to meet programs, whether, you know, you've been in practice for 10 years giving transcatheter valve therapy, or if you've been in practice for 10 months, there is a way to look at what your capacity is, and whether that's restricted, reduced, or whatever's your conventional cadence or capacity, and how you can look at what that's going to mean for your patient characteristics and the numbers of procedures that you can anticipate, because it doesn't mean that you have to completely shut your program down. We can't do that again in sites, and especially for our patients that are often acute in our transcatheter valve, you know, programs. We need to be able to continue to treat them and treat them at the right time in the right place. So how do we do that? And this manuscript really aims to assist with a programmatic approach and a framework that shows before and after treatment. Here are the criteria to look at, and based on what the resources are, here is a pathway that you can use. And if you can't treat them in your center, consider referring them out. And here are the remote work requirements, and here's the swim lanes, or the who's who and who can do what, in a way that keeps things skill task aligned, so people work top of license. And some additional pearls that really give some tactical guidance for sites who are often struggling with furloughs or, you know, redeployment to other arenas and so forth. So the point is that we have to try something, right? We've got to take our shot. And in implementing a treatment pathway, the call to action is really, what is one thing that I can better understand to implement change in my program, because we do have to understand something to transform it. There's nothing worse than somebody coming to you and saying, well, here's all the things you've got to do, and they have never walked in your shoes. They've never, been shoulder to shoulder or hip to hip, or even asked you, what does your day look like? And so understanding your role, but then also understanding the bigger picture and what these metrics are that you can see here. I've included volumes and trends for the clinical pathway for your outcomes, and really understanding what those goals are can really help you to then identify what you can transform in your program and what might be the highest yield for you too. And what I also must say is that a call to action now more than ever is to connect. Zoom has been terrific for this, to connect us, just as this Heart Team Summit is, and I really have to thank the course directors in this consortium for connecting to the cardiovascular team community at large. In the ACC, we have a cardiovascular team structural heart work group where we are sharing best practices, where we're working on elucidating the cardiovascular team member role in our processes and our programs, and I would love to see more contributions from the CV team. This is intended to, again, show us that implementation is always about people and teams. We can't implement anything alone. We must include the front line and end users. We need to begin with the end in mind, knowing our patients, our team, our program, and our center. And again, if there's a clinical trial, or if there's a center that has more experience with a particular approach or therapy, I'm never afraid to recommend that we speak to that team. We need to use evidence-based guidelines and implementation tools. And most importantly, we need to communicate. We have to communicate frequently. We need to share our successes and our challenges. There are lots of lessons to learn, and we can share those along the way with the community at large in forums just like this. So thank you very much for your attention.
Thanks, Liz. Our next speaker will be Hannah Pope. She is currently the cardiac intensive care unit and cardiac cath lab clinical pharmacy specialist at Barnes-Jewish here. She also serves as the pharmacy residency program director at Barnes-Jewish. She's going to be talking and discussing about the novel anticoagulants and antiplatelet agents.
Hi, everyone. Thank you so much for the introduction. I, as Holly said, was tasked with the challenge of talking about one of my favorite topics in just 10 minutes. So discussing antiplatelet and novel oral anticoagulants. So hopefully I'll be touching on some basics and nuances of these agents. So just back to the basics of why we're using these agents so you can better understand some of the concepts that I'll be going over. With acute coronary syndrome, if you're more familiar with these agents and the use of acute coronary syndrome, what we're really trying to do is target that platelet activation and inhibit that platelet activation when plaque rupture occurs in that acute phase of acute coronary syndrome and then on. I know many of you are also familiar or in part of the care of TAVR patients, and many times the use of antiplatelet agents can be seen in the care for, or are seen in the care for TAVR patients, and that's because there can be thrombus formation after TAVR, and this can be partially platelet mediated and has to do with multiple both patient and valve related factors and multiple contributing variables with this. But when we think back to what is actually happening when we have platelet clot formation, so we can understand why we're using the drugs we're using, I want to first start with platelet adhesion. So with platelet clot formation, we have that plaque rupture, an area of site injury that's now exposed, active. We have platelet adhesive proteins that these platelets now bind to these platelet adhesive proteins and form this monolayer of platelets at the site of injury. This is not enough to provoke usually a total occlusion, but it's the start of the thrombus formation. Then we have the second step, which is platelet activation, and several agents activate platelets. Several thrombogenic agents are now circulating around the bloodstream: thromboxane A2, collagen, thrombin, ADP. These are all things that we target with the drugs that we use for antiplatelet agents and antithrombotic agents in the care of these ACS patients. What is actually happening with platelet activation is that we have a conformational change of the platelet GP2B3A receptor. Now this GP2B3A receptor is exposed and active and ready for more platelets to bind. So we have circulating fibrinogen that now has 2 binding sites for the platelet GP2B3A receptor. One platelet binds to another platelet, and then cross-linking is formed between platelets and really promotes this thrombin growth. And we have this fibrinogen that then forms insoluble fibrin, and you have this fibrin-rich clot on the site of a vessel injury or the ruptured plaque that then can lead to total occlusion. If we're thinking about more of that landscape of treatment during PCI, STEMI, and STEMI patients that go to PCI, this is really, I just really wanted to show you a depiction of where these antiplatelet agents fit in the course of care, or at least the acute setting of acute coronary syndrome. You can see that the first 2 options that I have in yellow boxes, these are the options that are more of that are the guideline recommended therapy and options for care in PCI, STEMI, and NSTEMI. The third option that I've added includes Cangrelor, which is one of the newer IV P2Y12 inhibitors, and you will not find it in the current guidelines because it was approved for use after the guidelines have been updated. As I said, I was tasked with the difficult thing to talk about P2Y12 inhibitors, antiplatelet agents in just a short period of time. And as many of you know, there's so much that I could talk about with these agents, so many updates and publications that continue to come out that affect how long we use these agents, what we use in specific patients, what combinations of agents we may use. But really what I'm going to try to focus on is just reviewing the pharmacology and maybe some patient-specific factors of these agents. So we first started with the gold standard therapy that was, or what was the gold standard for so long, clopidogrel. And as we got more agents approved on the market in terms of P2Y12 receptor inhibitors like prasugrel, then ticagrelor and cangrelor, each one of these agents provided more potent platelet inhibition as they were approved. On this slide, I also have all of the landmark trials the main landmark trials that are associated with these drugs for acute coronary syndrome. So first, what I have is when we look back to the basics of the mechanism of action of these drugs and really understanding how these drugs are working that we're using it for this platelet inhibition. We have prasugrel and clopidogrel, which are thionopyridines. That's the class of P2Y12 inhibitors. They bind to the receptor, the P2Y12 receptor, and inhibit ADP from binding. ADP is what leads to platelet activation. They bind irreversibly to this receptor, so they're there for the life of the platelet, which really leads to that platelet inhibition for the life of the platelet, which could be anywhere from 3 to 7 or more days. Then we have ticagrelor, which is a different class of P2Y12 inhibitors. It's a cyclopentyltriazyl pyrimidine, or CPTP. This drug actually reversibly binds, so different in terms of binding, and it reversibly binds to a different area on the receptor, and it doesn't actually interfere with ADP from binding, but what it does is it prevents ADP-mediated platelet activation. So slightly different mechanism compared to the first 2 agents that I mentioned. And then we have our last agent, newest agent that's IV, cangrelor, which is an ATP analog, and this reversibly binds to the P2Y12 receptor site and inhibits ADP from binding, similar to clopidogrel and prasugrel. And this leads to a drug interaction that I'll touch on as we go. So this slide really just focuses on the indications, the routes of administration, and the doses. What I really want to point out is that there is a difference in indication. So you can see that both prasugrel and cangrelor are only indicated in PCI. Clopidogrel is indicated in invasive and medical management for acute coronary syndrome. Ticagrelor, same invasive and medical management, but also continues to grow in its labeled indications. So now has the addition of CAD and no prior stroke or MI, and now also stroke. You can see there's a loading dose associated with all of these agents, and then a maintenance dose. Something that another thing I want to point out that's unique, prasugrel, you may see a reduced dose that was done in the ICAR REACT 5 trial for patients' age and weight. You may also see a reduction in dose in patients, or reduce the dose in patients with ticagrelor, and this dose was seen in the Pegasus and Themis trial. And this is when if a patient continues ticagrelor past a year, you have the option of decreasing the dose to 60 milligrams BID based on the labeled indication in those two studies. So this table goes into more detail on the pharmacodynamics, pharmacokinetics of the antiplatelet agents. The main things that I want to touch on is that there is a difference in terms of some of these agents require, like clopidogrel and prasugrel, they require metabolism to get to the active drug, which may lead to a longer time to onset of platelet inhibition compared to, let's say, ticagrelor, which has a less variable time to onset of platelet inhibition. And then even compared to that, we look at cangrelor, which has the fastest time to platelet inhibition at 2 minutes once you start that infusion. And then there's a slight difference in terms of duration of effects, which really matters for those of you who see these patients prior to surgery and you need to hold these agents. And this really surrounds that irreversible binding and that potent action of the antiplatelet agents. And one thing I do want to, or something that I would like to point out, is cangrelor is one of the big benefits of the use of this IV drug, especially in that acute phase. If a patient does have to go to an emergent surgery, then once you stop this drug, within 30 to 60 minutes, you have platelet function return to normal. I don't have too much time to go into this slide, but I did want to provide a summary of the landmark trials. We have the CURE trial, which was that initial trial looking at clopidogrel and really studying it for patients with NSTEMI and looking at dual antiplatelet therapy. As we go, we have the Triton-TIMI 38 trial with prasugrel, the Plato trial with ticagrelor, and then most recently that ICAR REACT 5 trial comparing ticagrelor to prasugrel. When we look at ticagrelor and prasugrel compared to that what was at one time the gold standard clopidogrel, we see that prasugrel and ticagrelor provide, in the landmark trials that I just mentioned on the previous slide, showed benefit compared to clopidogrel when looking at the primary outcome. They both decrease stent thrombosis, a key secondary outcome. And then when you look at prasugrel, we did see an increased risk of life-threatening fatal bleeding, and then a trend towards an increased risk of bleeding with the use of ticagrelor. Both of these agents are more potent in terms of platelet inhibition, so something we would expect. Cangrelor, when you look at this agent compared to clopidogrel in Champion Phoenix trial, at 48 hours, we saw a reduction in the primary endpoint. Then we also saw a decrease in stent thrombosis at 48 hours, and you'll find that there was a trend towards an increased risk of bleed, but no significant increased risk of bleed with the use of cangrelor compared to clopidogrel. Some patient-specific factors that I think really come into play when trying to decide what agent should we use for a patient, or things that we should take into consideration when deciding on agents. Clopidogrel, we have to worry about these drug interactions because this drug does have to be metabolized to an active metabolite. There's interpatient variability due to loss of function allele, which can affect at least 30% of the patient population, if not more, up to 55% in specific patient populations, but it is generic and least expensive. Ticagrelor Cangrelor has the unique adverse event of dyspnea. It is a strong, and it does have commonly overlooked drug interactions with CYP3A4 inhibitors and inducers. It has BID dosing, which you have to consider when you're considering compliance. It is contraindicated with aspirin doses that are greater than 100 milligrams, so you must use less than 100 milligrams. It is the only oral drug that we have labeled. It has labeling and PK pharmacokinetic studies for per tube administration, although we administer all of these per tube for years. Prasugrel was found in the Triton-TIMI 38 trial to have harm and little benefit in patients greater than or equal to 75 years of age or less than 60 kilograms, and there was an increased risk of intracranial bleeding in patients with a history of stroke or TIA, so it is actually contraindicated, and there's a black box warning surrounding the use of prasugrel in these patients. So something that you must screen and know the history of when prescribing or choosing these agents or choosing prasugrel. Cangrelor, it's a weight-based dose, it's IV, it requires a dedicated IV line, and it doesn't have to be adjusted for age. And the dose doesn't have to be adjusted for age, hepatic, or renal dysfunction. And there is a drug interaction that must be taken into consideration when transitioning from clopidogrel and prasugrel if you must avoid administering these agents at the same time as the Cangrelor is running. Something interesting that I wanted to note that was updated in 2018, Ticagrelor, prasugrel, and clopidogrel all had updates to their labeled indications due to various trials showing, or various studies showing, there was a decreased exposure to these agents when used in combination with an opioid. So these labels now actually recommend the use of Cangrelor or the use of an IV parenteral agent, antiplatelet agent, if opioids are used, such as morphine or fentanyl, that may decrease the exposure to the oral agents in that acute phase of the MI. So those IV parenteral agents that we have available are Cangrelor and then the GP2B3A inhibitors. Cangrelor is that agent that I talked about. It has very quick onset of action within 2 minutes, platelet up to 98 to 100% platelet inhibition, quick offset of action within 30 to 60 minutes, but it does have an interaction, so you must transition these patients to one of the oral agents after you administer this for 2 hours or the duration of PCI, whichever is longer. And when you administer the clopidogrel or prasugrel, if you transition to these agents, you must administer these after the agent of the Cangrelor is stopped. This is a major thing because if you administer them during the infusion, these doses will be negligible and these patients may not get the dose until the next, or get the adequate drug dose until the next day, and could potentially even miss the loading dose. I did place a very small box at the bottom of the screen for the Cangrelor bridging dose. So if we do have to stop one of these oral agents and prior to a procedure and the patient requires dual antiplatelet therapy and we don't want them to go without a P2Y12 inhibitor, Cangrelor is an option to bridge, but it does have a lower dose at 0.75 mics per kilo per minute, and that's not a labeled dose. Dosing or indication, so that's off label. The other IV agents that are potential options are eptifibatide and tirofiban. These are GP2B3A inhibitors. They notably do have a quick onset of action, but when you look at normalization to platelet function, it's longer than when you look at Cangrelor, so about 4 to 8 hours. And it does have a potent platelet inhibition of about 90%. Both of these are renally excreted and require dosage adjustment because they can accumulate in patients with renal dysfunction, and which would then in turn lead to an increased risk of bleed. So I know I'm really running towards the end of my time. I do have a few slides on direct-acting oral anticoagulants. This shows a timeline that I think is very impressive, especially starting around 2010 when we really had the influx of new oral anticoagulants that came to market. From now to, you know, the latest in the last few years, Betrixaban. In 2010, we had dabigatran followed by rivaroxaban, which now has six indications. So we've seen a growth in agents, an addition of agents, a growth of indications, different doses for different indications that you must pay attention to. And then we have multiple reversal agents that now can be found on the market. With these agents, we have decreased monitoring that's required compared to warfarin. We have decreased risk of bleed and all the studies that have, all the landmark trials with these agents. And then we also have ease of use compared to warfarin. This slide really just emphasizes or shows and depicts the mechanism of action of these agents that we now have available for direct-acting oral anticoagulants, the clearance of these agents, which is very important to take into consideration because many of these drugs require adjustment for renal dysfunction or have contraindications in patients with renal dysfunction or precautions surrounding it. I think one of the biggest challenges that you can see on this slide that I have is the monitoring of these agents. So we don't need to monitor these agents with INR as we do with warfarin. It requires less monitoring than these agents, which is really, or than warfarin, which is really a big benefit of these agents. But it's also a challenge because when we do need to know the extent of anticoagulation or whether one of these drugs is present in a patient, then we really have an inability to do that because many hospitals throughout the country don't have specified assays that are calibrated to detect these drugs of interest, which leads to challenges when we have to figure out how long should we withhold these agents and what should we do prior to procedure, whether the procedure is emergent or planned. And that's why I really included this slide. There's recommendations that were published in 2017 that have durations for withholding these agents. That really depends on the risk of bleed for the procedure and the creatinine clearance or renal function for these patients because the half-life of the drug may change. So here, this includes those recommendations. And then my last slide really shows now we have multiple reversal agents for these patients, or for these agents when used in patients that need reversal. That was one of our biggest challenges when these agents first came out. There was no option for reversal or very limited options for reversal. With warfarin, we did have that option if we needed to. So this really depicts the options for first, second line, and what can be used with these newer or novel anticoagulant agents. And that summarizes, or that concludes my presentation. Thank you.
Thanks, Hannah. Our next speaker will be Ann Cunningham. She is a acute nurse care practitioner at John Cochrane VA. She works in the critical care setting, both in the operating room and surgical ICU, managing post-op patients. She has 40 years of experience in the operating room and 20 years as a acute care nurse practitioner for cardiothoracic patients. So she's well-versed and be able to talk to us on managing multidisciplinary work environment. Go ahead, Marianne.
Okay, thank you. The multidisciplinary work environment was my topic, and so we thought that we would share with the team the first cardiac surgery program that was started in the VA system in 20 years in 2015 here at John Cochrane VA. In 2006, the chief of staff, who was an ophthalmologist, was interested in opening a heart surgery program. And the VA did a study and conducted the patient volumes, and Cardiac Surgery Advisory Board site visit was the start of this process. So the data came back that in 2012, we had done 832 coronary angiographies, 512 percutaneous coronary interventions, which was reported as the highest number of coronary interventions nationally. And that's, they thought, was predictive of future demand. We had a summary of recommendations from the board, which were quite extensive. Nursing leadership needed to establish the standards of an ICU with evidence of adequately trained nurses and personnel. We needed to have dedicated cardiac anesthesiologists. We had to have a close affiliation with a university. We needed evidence of blood bank capabilities for mass transfusion of all blood products. We needed to recruit surgeons from the general and vascular area along with thoracic, and we also needed to recruit a full-time cardiothoracic surgeon. Dr. Crittenden was recruited from the busiest open heart program in the VA administration, and he became the full-time chief of surgery here at the VA, and he was also associate professor of surgery at Washington University School of Medicine. He too quickly realized our need to elevate the quality and complexity of the care provided by the surgical services in order to gain approval for an open heart program, and this required the clinical restructuring. The VA system also rewards hospitals that do higher acuity cases, and with cardiac surgery would be at the top of that list. Dr. Crittenden was the chief of cardiac surgery at the Boston VA, and he was also the professor of surgery at Harvard Medical School. Then in 2013, the business plan was submitted for anesthesia, critical care, and cardiac surgery approval. Also, Dr. Spencer Melby came to the VA, and Dr. Kachukas retired. And 5 members of his team that we all worked with him at Missouri Baptist all decided to come and work together, continue our work at the VA with the new heart program. So that began our work on the critical structure. Our first case was done in March of 2015. So many of our needs were met by the Surgical Critical Care Service. We hired intensivists, 3 acute care nurse practitioners. They started a 24-hour coverage and ICU training. We needed a clinical nurse leader, so I was hired and with cardiac surgery experience. And I started recruiting the nurses that I used to work with to come and work with me. We needed a specific anesthesia that was specific to cardiac surgery. We needed cardiology support, which was already established here. And the laboratory needed some point of care. We instituted the point of care, which beefed up their already supportive services. The blood bank we needed to have urgent needs established in the blood bank. And the rehabilitation support for post-op patients. We have an existing superb reputation at the Jefferson Barracks. There's all kinds of rehab programs at Jefferson Barracks. So it was just, that was a good fit. The OR infrastructure we rehabbed our existing ORs and the nursing staff for cardiac surgery. And we want to thank Dr. Kachukas for sharing and giving of his talents over the years. The resources committed to date at the VA central office were 3 site visits, $2.5 million in equipment and instruments and disposables. Almost 35 new FTEs were hired at the VA, and most of the anesthesia, nursing, and support staff were trained at other VA hospitals, Tampa and Columbia. Our surgical team consisted of 4 board-certified cardiothoracic surgeons, but only 2 were going to be doing the cases, and 1 surgeon retired. As I said, in 2014, Dr. Spencer Melby joined the team and then he became our chief of CT surgery. In 2017, Dr. Faraz Massoud joined the team, and they're both from Washington University. We have one perfusionist, one full-time perfusionist, and we have two, and now a third contractual perfusionist is in the works. We have 3 NPs, myself, Christy Leifer, and Michelle McLeod. We also cover the thoracic surgery service as well. The cardiac surgery team, this is our operating room team, and 4 of the 7 nurses on staff have worked between 15 and 25 years with Dr. Kachoukas, and they came to the VA to continue sharing our skills and caring for our veterans. Hardly a day goes by that we don't mention Dr. Kachoukas would have just said this or he would have done that. So we're all still very much trying to carry on his work. Our go live plan, we had a simulation for surgical cases. We had patient care emergencies. You can see our resternotomy cart, and we made it very simple. 1, 2, 3, you open those drawers and open things. And we did save one patient's life who had a tamponade post-op, and we opened him in the unit and he walked out the door. So that cart has paid for itself. Our system, we did system related emergencies. We did transport emergencies because we do send some of our very higher risk patients to Barnes Hospital. So we needed to make sure that transporting was going to be safe and how urgent we could make it happen. And we needed to have a consensus from everyone before we had our ready to go and our first case. So we did our first case, I said, in March of 2015, and then we did number 100 in June of 17, 200 in April of 19, and we're almost at 300 to date. Lessons we've learned is to hire a staff early on, especially a well-trained staff with a critical care skill set. The veteran population is a different population. Our average STS risk score is very high, and they are a very grateful group. It is very rewarding to be a part of this team. We work as a partnership, we work in collaboration, and we work with mutual support. The way that it works is when we get a consult, the nurse practitioners will go see the patient. We will do the H&Ps. We'll make sure all the testing is set. We'll run the STS risk score, and we collaborate daily with Dr. Melby and Dr. Massoud. They come over to the VA on Mondays and Thursdays and operate, and for the most part, the rest of the time is of our team is run by the nurse practitioners. It's not a hierarchy. It's a true collaboration, which makes it a real joy to work in this system. The VA system also has many resources. Not only do we do the cardiac surgery on our patients, but any issues that our patients have, which many times are social issues, or if we need to, if we notice that a patient has sleep apnea in the post-op setting, if a patient has issues with diabetes control, we have many resources in the VA system for our veterans. They also get all their medications for free through the VA. And the issue with us is we need to have patience, because even though we have many resources, it's also a very layered system and it takes time. But if you learn the system and you learn your way around the system, you can really provide amazing care for our veterans. We do take ownership with our patients too. They call us back for almost everything, and it's not uncommon for them to just stop by in our clinic, say hello. Just was here for another appointment, and we wanted to stop by and say hello to everyone. We also learned to celebrate our successes. We've done 280 cases to date, We've had one single mortality, which was our patient number 20, who died after discharge to home. We've had one single sternal complication of a patient who dehisced his sternum with a cough that was like a bomb going off, and he dehisced his sternum. We took him back to the operating room on a Saturday, and he ended up with flaps being swung, and he continues to call periodically to let us know that he's doing well. Our average length of stay is 7 days. And when we first started this journey in 2012, the VA here was ranked 97. We are now ranked 28, and that has happened in 2 years in a large part to the fact that we have a cardiac surgery program here at the VA. The next project we have is the number one approved project in the VA system. The brown hospital that you see in that picture is where we are now, and the kind of glass area is the plan for the next 5 to 10 years of a new hospital being built here on the same area. Due to the dedication of excellence and the procedural complexity of the 1A VHA facilities, we are now currently in the process of a $5 million project of a hybrid room, which we hope to do TAVRs. This room is supposed to be finished in the summer of this year. When we did our 100th cardiac surgery, we celebrated and invited all of the veterans that we had operated on. And as a matter of fact, 36 of them showed up. We had a celebration, we had hats, it was really a wonderful tribute to, I think, our program, that so many of them wanted to come back and say hello and celebrate with their colleagues. We know all of them. We still know them. We see them in the hallways, and they they remind us of their date, and many of them know which number they were. This is number 100, and he had our first patient was a mitral valve replacement. Our 100 patient was a mitral valve repair. And you see Cherie is our chief nursing officer at the time. She is giving him a hat. They all got hats, and the hats say 100th cardiac surgery program. And we hope to do this again. And the whole process, I basically went over all the clinical portions, and it was truly multidisciplinary. And we are a pretty lean team, so the skill set is key. But I think our humanitarian approach to caring for our veterans is what makes this such a rewarding adventure. So thank you very much for your time and consideration. I hope you enjoyed this journey with me.
Thank you, Marianne. So our last speaker we have is Connie Wagner. She's my one of my coworkers here, my cohort here at the Valve Clinic here at Barnes for the Valve team. She has a background for taking care of high-risk cardiac patients. So take it away, Connie.
Thanks for everyone for participating. I know there's a diverse group that's on the call, and some of you may have come from sites that have been doing TAVRs for a long time. Others may come from programs that just started. And just to emphasize that fact, so according to the TVT registry in 2012, which is when they started keeping track of this, and for some reason my screen isn't working. So let me see. There we go. There were 145 sites in 2012. Over 3,000 procedures were done. And compare that to 2020, there's over 700 sites, even though the final numbers haven't been published yet, but over 86,000 procedures were completed. So obviously within the last 8 years, a lot of new programs have come about. So I'm going to use WashU and Barnes as a reference point just to give you an idea of how our program has changed and how our communication problems and challenges have evolved, and what we're doing not to hopefully drop the ball in dealing with the patient. Our program here started in 2008. There were 13 cases, and the TAVR team consisted of about 5 individuals. It was an interventional cardiologist, 2 heart surgeons, 2 research nurse coordinators. So communication was pretty straightforward. Not very many cases, easier to manage, that type of thing. So now fast forward to where we are today. And this past year, we did 182 cases, and that's still taking into account all the COVID impact. We have clinic 3 days a week. We utilize 3 different clinical sites, and the doctors have 3 procedural days. And they use a combination of a hybrid room and the cath lab and the OR. So there's a lot more to keep track of. And our TAVR team now is about 12 core individuals. It's 4 interventional cardiologists, 3 heart surgeons and 2 senior advisors, 3 clinical nurse coordinators, 2 research coordinators. I said 1+ nurse practitioner because we kind of borrow from here and there, a medical assistant, and then obviously all the other departments in the hospital that we use. So it's a challenge to keep our team up to date, let alone all the patient families, and all the other team members involved. So what does this mean for patient follow-up? More volume equals more opportunity, which is so great. That's what everybody's hoping for. But also more volume means more challenges. And that is something that we all dread. It's not so great. There are the patients that not only that we're following up on are also much more complicated and with chronic and complex needs. We used to get maybe the straightforward case before a lot of other programs started. And now the patients that we get are really complicated. So there's so many areas where potentially the ball could be dropped. We go through the initial evaluation scheduling, the evaluation testing, and then any ancillary testing, because as you know, with a lot of these older patients, we have incidental findings, and then they have to be routed off for some additional testing, and then we have to keep track and then make sure that they come back to us and we follow up. Then we have the testing results and the next steps, procedure scheduling, procedure follow-up. And it's not just with the patients, it's with the patient's family as well. So that's kind of I feel that the TAVR coordinator in the middle there is kind of doing this juggling act and trying to keep it all in flow. And so now how not to drop the ball. And as you all know, I mean, this is not rocket science. This is not brain surgery work. But I'm telling you also that really I'm a pretty detailed person. And so when I took this position, I thought, oh, this is right up my alley. And there are days that at the end of the day, I think, what just happened? Like, what just happened? We have so many messages in Epic, our computer system. There are people calling, texting, emailing, and it's not just the patients, it's the doctors, it's the patient's family, it's team members, and really the list goes on of all the people that you're trying to keep in touch with. So in the tips I'm going to cover on not dropping the ball, the key overriding element is communication. And it seems like such a basic statement, but it really is one of the most important task management strategies that you can use. And it's a little bit more time consuming up front, but if you can prevent so many last minute issues by at least investing the time up front. So once again, I mean, there are plans that our teams, procedures, TAVR programs that are just getting started. So maybe some of these tips will be helpful for programs that are well established. You're going to say, yeah, we know that, that's what we're doing. So, but first off, the main thing is to have a plan. And there's a saying that it wasn't raining when Noah started building the ark, which means he had a plan, you know. So find a system that works for you to track all of the valve patients. And if you know the plan for each patient, it's easier not to drop the ball. And utilize your interdisciplinary team. Like Marianne was just talking about, we rely hugely on an interdisciplinary team. And if everyone knows the plan, they may be looking at the plan also, but they might be looking at for different details. They might have something else in mind. So, but if everyone's trying to manage towards the same plan, once again, there's less chance of missing something and less chance of dropping the ball. Use any electronic resources you've got. Like in Epic, we have a Remind Me tab, and it's great reminders for tabs, for blood pressure readings and COVID testing. And then always try to be one step ahead. Ask the if, then, what type of situation. Have a plan B, know what else is coming down the pike. Which also leads into the ripple effect. If a change does take place, make sure that you go back and circle through and communicate with all the people that the change affects. And for example, if we add a patient to the schedule at the last minute, you know, the procedural staff needs to be aware, the reps need to be notified, the patient labs need to be current. It is a huge ripple effect, just like, you know, how they say the stone in the pond, because you just have to make sure you circle back with everybody. And I'm old school, so keeping a notepad nearby is always good. And I'm a type A personality, and there's nothing like waking up at 3 o'clock in the morning and rolling over, and I can just write one little word, and it at least reminds me in the morning so I can go back to bed. There are so many details to keep track of, as I'm sure you all are aware, but just any sources that you can keep in mind and use, and whatever works best for you is what's going to make it successful. And utilize the patient's family. As we said, most of these are older adults, and they come with a supportive and protective adult children. If in an ideal situation, that's what happens. And if you say, for example, okay, let's touch base at the end of the week, guaranteed, if you haven't called them, they're calling you. And that's perfect. I love to have that, because once again, it's just utilizing a backup so that nothing goes through and falls through the crack. And then put yourself in the patient's shoes and the family's shoes. Have you given them the information that they need? And that's something that I think you have to think about really on a daily basis. And that's the next thing, of set a daily plan and knowing that you're going to have to make adjustments. There are very few days that really go according to what I think they're going to go, but at least each day I start with a plan, and then I can circle back and see where we are. Constantly be reviewing the patient list, knowing where the patients have testing, who's being scheduled, who needs a patient disposition, who you need to track down the doctors and get some feedback for, and then set priorities accordingly. And if the ball drops, and that's a flat out statement, because it's going to happen. So if a ball drops, which it will at some point, acknowledge it, learn from it, realize it's a group effort, and see how you can prevent a similar situation from happening in the future. And you have to constantly be willing to reevaluate your processes and your procedures, make adjustments, and figure out what is going to be in the best interest of the patient. As the previous speakers have said, this is a team approach. And according to a discussion paper from the Institute of Health, they're saying is the high-performing team is now widely recognized as an essential tool for constructing a more patient-centered, coordinated, and effective healthcare delivery system. A team approach is becoming the standard of care. And truly, to the patient, they don't care who catches the ball. They just want to make sure that people are there to catch the ball and that people are on their side and looking out for them. So who should benefit the most from this is really the patient and the patient's family. And thank you for your attention and your consideration. And Holly, I will pass it back to you.
All right, thank you, Connie. I want to thank all of you, the speakers this evening, for sharing your wealth of knowledge with us. I think we've went a little bit over time, so for discussion, if anyone has any questions, they can just email at the cvconferences@northwestern.edu for any questions you might have for any of the speakers.
Elizabeth, Hannah, Marianne, Connie, you are all stars. That was fantastic. Thank you so much for sharing your expertise with us and our audience. Our next session is going to be on February 17th at 5 p.m. Central. We've got great talks on CVA and interventional approaches. That will be followed shortly after 6 p.m. by a sponsored session from AstraZeneca on stroke and TIA management. So please come back in 2 weeks and catch that. And thanks again to our speakers, our panelists, and our audience. And everyone have a great night.